Thank you, everybody, for coming to this event. Thank you, KKR, for hosting. We're so incredibly excited to work with you. And we've been working with KKR over the last few months on helping us think through how we can serve our community health center partners better. What are some of the things that we can do together to help FQHCs solve some of these very fundamental problems that for such a long time have been relegated to more manual, time-consuming solutions to something that's more automated, to something that's more 21st century, using something that almost every single person has in their pocket, which is a cell phone. And so that's the concept behind CareMessage. That's the reason why we have built this organization, is to empower people at FQHCs, at health centers, to be able to do more with less, particularly in an environment where FQHCs are being asked to do more. They're being asked to take on value-based care initiatives. They're being asked to provide referrals around social determinants, which is part of the conversation we're going to have today. And there's more and more constraints on the resources that are available to organizations that are serving this segment of the population, 30 million people across the country. So we hope to be one way that organizations can help achieve those objectives through the resources that they have that are ever shrinking, ever constraining, ever at risk, particularly in the environment we find ourselves today. So excited to be able to share more about that. But more importantly, I wanted to introduce Sonia Panigrahy from CHCANYS, which is the agency in New York that oversees policy, administration, and just helps so many of the health centers in New York State be more effective. And Sonia specifically leads quality and technology efforts. So really excited about this discussion around social determinants, because we know that so much of health is tied directly to some of these underlying factors that are not necessarily clinical in nature. So excited for a robust discussion around that topic, and you'll be hearing from me a little bit more towards the end of the conversation, but for now, let me introduce Sonia. Thank you.
Thank you. I think this may work. This does work. I want to turn this on. All right, good evening. So my name is Sonia Panigrahy. I work with CHCANYS. It's Community Healthcare Association of New York State. We're a statewide primary care association. So most states have this type of an entity to oversee the federally qualified health centers for a given state or group of states. We oversee about 70 clinics statewide that serve 2.2 million patients every year. And the majority of our patients are Medicaid patients, underserved, definitely a lot of complex medical needs, and a whole host of social needs that can really undermine a patient's ability to take care of themselves, and also undermines a care team's ability to take care of the patient. So I'm excited to be your moderator for today. The panel will feature 3 panelists. It'll be 45 minutes, and then we'll have 15 minutes afterwards for some Q&A. So I'll first ask our health center folks to introduce yourself with your name, the role at your health center, name of your health center, and patient population in terms of volume.
Okay. Want to go first?
If you could go first.
All right, great. Good evening, everyone. My name is Tom Marino. I'm the Chief Transformation Officer at Harlem United, and our federally qualified health center is called the Nest Community Health Center, located on 133rd Street on the Upper West Side. We're a federally qualified health center for the homeless specifically, so a little different than our sister agencies. We serve about 65 to 75% homeless population. Harlem United started 30 years ago as a social support for homeless HIV positive men living on the street, and we started in a church basement, and we evolved into the federally qualified health center. So about 40% of the patients that we see in our health center are HIV positive. The other 60% are negative. And we see a variety of people from substance using, mental health, diabetes, cholesterol, the routines, and of course HIV. We do on an annual basis, about 13,000 primary care visits in primary care. We've just started some specialty care in cardiology, podiatry, and GYN, and we expect to expand the practice to be another 3,000 visits in that area, building upon the foundation that we currently serve. And then in our dental clinic, we see about 6,000 visits a year and about 7,000 visits in our Article 31, which is a behavioral health freestanding mental health clinic.
Great, thank you, Tom.
Thank you.
Now it's for Jasdeep to go next.
Hi, good evening. My name is Jasdeep. I'm at Ryan Health. Ryan Health is another FQHC. We have 18 service sites, and in 2018 we saw about 48,000 unique patients. My role with SDOH is I'm on the IT side, so I'm an Informatics Population Health Analyst. I was more involved with SDOH with the project support, implementation, and helping with the data aggregation. In the FQHC realm, we're easily able to claim our patients are complex, but without being able to capture that data, we're not really able to act on it or provide the numbers for getting other grant services or support that we may necessarily need. So that's my role, more from the IT informatics perspective.
Great, thank you. And I asked for Adena to go last because you represent a foundation.
Yes.
So I'd love to hear a little bit more about your name, where you work, and your organization's role in supporting social determinants.
Yeah, so my name's, good evening. Thank you guys for coming on a Monday evening. My name's Adena Hernandez. I'm a program officer on the health team at Robin Hood. Robin Hood is New York City's largest poverty fighting organization, funding kind of the top performing programs and organizations, including Ryan Health, across the 5 boroughs of New York City. And I think in a lot of ways, Robin Hood embodies the social determinants of health across. We have 9 different portfolios, including health focus kind of very holistically on how do we address poverty. So we fund everything from job training to income security to housing to early childhood to K through 12 education. And I think one of the things we're focused on is how do you kind of overlap and really integrate those things. And I think our partners within the health system, including hospital systems, FQHCs, are really focused on how do we kind of address kind of these really complex needs of our populations, and we do all that we can to enable that.
Great, thank you. FQHC is such a hard acronym. We'll just call them community health centers. I still struggle with it. So, Adena, I'm going to ask you if you can tell us. So, social determinants, or SDOH, social determinants of health, it's quite the buzzword, and a lot of us throw that around. How do you define that at Robin Hood? What does SDOH mean at Robin Hood?
Yeah, so I think there's kind of 2 strains that the SDOH have gone really, and I think kind of for the focus of the health centers and hospital systems that we plan, it's really about addressing the individual needs of your patients, which are so critically important. I think at Robin Hood, given kind of the kind of funding and influence that we can have and the support that we're able to provide to our partners, we really try and think about it kind of that step back, thinking about how do we address the social conditions that people live in? How do we create systematic change and kind of shore up the resources within a community so that we're really changing social conditions within those communities. I think individual needs are so important, and that's really what's in the scope as a health provider you can address. But I think for us, we really try and enable our partners to be able to be part of a larger system, addressing the really complex, systematic, historical systems that provide barriers to care, to create disparities in health. So I think we are able to kind of have a broader lens on what the social determinants of health means. And I think we're thinking more and more about how do we impact policy, how do we change systems to enable our partners to be more effective and to really serve vulnerable communities.
And when you say social conditions, what do you mean by conditions?
So thinking about what are the types of policies, what are the isms that are in place, racism, sexism, all of those things that impact it. The housing system, knowing that housing is probably the top things that our health centers and health providers are hearing about. So how can we really shape policy, invest in systems so that there's a robust housing system? How do we help our partners navigate within the health system, value-based care, and really provide and create those connections to job training services, making sure that people have access to really high quality job training. So I think thinking about it from that level.
Great, thank you. And for health center folks also, how do your clinics define social determinants? And why did you decide it was important to start collecting them? I'll let you go first.
So it's funny, when I've heard social determinants of health, my key reaction has always been Harlem United's been doing that forever. It's what we were about from day one, about addressing the social conditions that people are living in or not living in. You know, housing, we've always seen at Harlem United housing as part of healthcare, and we've demonstrated that over our 30-year history that if you can provide housing, you can really improve health outcomes. I mean, 77% of our patients that live in our housing are undetectable. They have an undetectable viral load. So the impact right there, it's so important to what we've done for 30 years that it's like a no-brainer to continue to collect that information and put that information together. So we've started using a tool within our EMR where we're collecting the things we've always collected, but in now a more structured and reportable way. So looking at people's income, looking at people's opportunity for employment, looking at their housing status, looking at their relationships. What victims of domestic violence, are they safe in their homes? Do they feel comfortable? Because at the end of the day, everything that we do socially, everything that impacts our environment is going to have an outcome on our healthcare. And we have to address those things. And the job of the primary care provider at Harlem United is very complex. It's not just taking care of the physical health. It is addressing those needs. I'll never forget when I started there in 2010, the first time I was there. I've come back in the last 2 years. But in 2010, I'll never forget someone saying, a patient saying to me, I really don't care about taking my medicine because I don't know where I'm putting my head to sleep tonight. And I don't know where my next meal will come from. And if there was anything that resonated for me around social determinant of health, it was that. That's a key important thing in the work that we do every day. So it has to be part of what we do. It's not an option. It's an essential way that we have to live our experience and help the clients that we take care of.
Great, thank you. And Jasdeep, how would you also talk about how Ryan Health defines social determinants and what was kind of the catalyst or the reason for starting to collect?
So at Ryan, SDH data was always being collected at the macro level. We were getting income status, we were getting homeless status, but it was never really at the micro. So at the micro level, SDH is, if it's not asked, it's unaddressed. And in my role, and being able to develop a standardized way to capture this data, we're able to report about what it is that we need, what are our needs, what are our patients' needs, especially serving such an uninsured or underserved population, and then from there having the ability to aggregate that data, because ultimately data impacts research, which drives policy. So being able to start something, implement the project, and hoping that ultimately we could get to that macro level and serve our population. So macro level, we're doing it. Micro is what we're trying to build a capacity for, and we're also exploring different structured fields to identify these patients and then help refer patients or close that loop and making sure the patients get the services they need.
Great, thank you. And what Jasdeep was starting to refer to is that a lot of our clinics, because we get federal funding, have to do an annual report called a UDS, Uniform Data Report System. Thank you. And so a lot of this information is already being collected, but it's a very small subset of what we know our patients actually are going through. So thank you. So for those of you who've been involved with doing research, collecting data, aggregating data, were you surprised to find that your clients or your patients were experiencing certain social issues that you were not aware of? And I'll give you an example. At CHCANYS, we're helping a number of our health centers implement a tool and screen, and we were working with a center that had a high homeless population, who would actually screen first as their social issues was food insecurity. So it was something that the health center thought they knew until they collected the data. So Thomas, you're nodding your head.
We kind of known our population for a long time, and we have a food pantry at our 290 location where we do a lot of preventative services. So, and we have a food and nutrition program in the evenings in the same place we have our adult day health center for HIV positive. So food has always been a core part of what we've done. So, there's a lot of things that are changing in our population that we adjusted to and are adjusting to in making sure that people who are seeking asylum have safe places to go, that they get the care that they need, making sure that people who are victims of cultural and things like female genital mutilation, we're starting practices for that because in collecting questions around safety, it's come to our attention. West African populations and other populations, there are women now living in our communities. They've been here for a long time who, were victims of FGM, and we needed to do something about that. So in doing that, we've started a whole holistic health women's initiative to address not just the physical, but to address the mental health and the housing needs that they're going to need. So it really, when you ask about safety in people's homes, or where they're living, you find out a lot of stuff that you don't know about, and it's like another form of violence that we don't think about, and it's that was a big eye opener for us. So we've put that initiative in place as a corrective action to really improve. So that was a big eye opener. So the things we knew, we kind of continue to know, but the things we didn't know, we have to take action. I think that's the biggest thing about SDOH right now, is that collecting the data is not good enough. We have to take the action to do something about it, to fix those things so that people do better and have better outcomes.
Thank you. Adena, and I'd love to hear from you too, because we were talking before and she said we tend to zoom out and see things at a kind of a bird's eye view. So I'd love to hear about your perspective as to certain social needs that you realized as a funder people needed, and maybe how some of those social needs have changed, as Tom referenced.
Yeah, I think we all kind of know some of the big social needs, especially in New York City. As I mentioned, housing is a huge one, as well as food insecurity. I think some of the surprises that we've heard from our partners, perhaps for the people who work in the health centers, are not super surprising to you, but I think transportation is a huge one. And we were talking to some of our partners at Montefiore, and they were saying simply by having transportation available and being able to shuttle their patients back and forth, they were able to reduce their hospitalizations and ER visits by a substantial amount. So that was huge for us, and that's a solution that's tangible that hospitals can put into effect, and I think that was really compelling to us. I think the other one is often childcare. It's how do you figure out if you have an appointment, if you have to go talk to a certified diabetes educator, you have to go to kind of one of your classes. How do you figure out how to manage your kids, or can you bring them with you? So I think it's really about how do you navigate the complexities, kind of the little complexities that turn to huge complexities in patients' lives. That kind of at Robin Hood, that's not often the focus of our issues, but listening and learning from our health partners and hearing what their patients are saying was really informative to us. I think you touched on it, but I think kind of given the political, social environment that's currently that we're all experiencing right now, we are seeing kind of just in terms of some of the social needs, it's immigration, legal services, things like that. Domestic violence is the #1 driver of family homelessness. So how do we address that issue? So I think those are the things that are emerging, and we're constantly trying to keep an eye out towards, listen to our partners, and figure out, are there ways that we at Robin Hood can make greater investments and to support you.
Oh, great, thank you. Jasdeep?
So some of the challenges, going in, we knew we were going to have difficulty with the homelessness and food insecurity, but from screening our patients, we learned there was a lot of attention for job security and child care services. So it was interesting to see that, but it definitely did highlight how we do need more resources. We need more staff to be able to provide the enabling services to connect our patients with the resources they need.
That's great, thank you. I was talking to some of the panelists, oftentimes our clinics, before SDOH really became the buzzword, we're afraid to ask patients, as a don't ask, don't tell situation, because the staff would say, well, I don't want to ask and open up this can of worms. that the patient has all these issues, and then we don't have an ability to actually do something about it. Right? A patient says that they're facing domestic violence, but you don't know about shelters, or your shelters are full and not taking any new, people. Then what do you do as a health center to address that? So, Tom, you referenced, opening up a women's center once you identified some women's health issues.
Mm-hmm.
How about for Adena and Jasdeep? Have you also, once you found that data, did you take any actions to address it? And if so, have you seen any difference in your population's ability to kind of take better care of themselves?
We're still in that capacity building state, so we're definitely, the main approach right now is rather assessing SDOH. The data is there, and it just keeps highlighting how we need more resources. So the action it keeps speaking to is the need for these resources. We really haven't been able to act upon the data to bring in the services that we need, or the resources. We did try some tools, but still there's a definite need for having additional resources to connect the patient to the services they need require.
So resources within the health center.
Within the health center, or possibly other community partnerships, they exist, but it's not at the level that we would need it to be in order to get the patients the services they require. Because again, you can refer a patient to a food pantry, or you can refer a patient to a patient navigator, but knowing if the patient actually follows through with that appointment or receives the service they need, it kind of gets lost, and we're not really able to say we actually addressed something without being able to know that the resource was available at that moment.
Correct. That's a good point. And Adena, Tom, would you like to answer that question as well?
Yeah, I think in terms of kind of how we address some of the emerging needs that we see, I think we have, with the kind of immigration, legal services example, and domestic violence example in particular, I think we have kind of investments in those areas historically. I think kind of as we see that becoming an even bigger issue and affecting more of the population, we try and think about how do we scale that? How do we create evidence-based, strong models that we can then disseminate across New York City, ideally New York State. So I think it's really about how can we cultivate partnerships with the government, with local city and state governments, bringing models that we know are effective in addressing the issues of domestic violence, of maternal depression, which we know a lot of survivors of domestic violence face, and kind of proving out models, and then having the city kind of with their kind of much larger budget than Robin Hood be able to scale and impact a greater number of individuals. So I think that's really how we try and address if we see that there's a growing need. We know that funding kind of even the best programs, it's still a limited population that's impacted. So how can we really scale that?
I think she hit on a key point with the partnerships. It's finding the right community-based partnerships to provide the service that you can't yourself, because we can't take all those resources away and do everything. We have to find the partners. Every time our business development team is out, we're looking for opportunities to partner with someone who can provide legal services, someone who can help with insurance enrollment, someone who can help with those things, because those all build up. When, as an FQHC, we can't refuse anyone on the inability to pay. And, even when you have that conversation about self-pay and what that means, the patient winces because they don't have the money to even pay that small copay that they would have to pay. So it's making sure we get them connected to the right services, to do our best to get them the insurance so that they can be seen comfortably and not have to worry about that. And from a transportation standpoint, another key point, we, within our network, we have a jitney service that runs through all the places that we have housing, and that has helped to decrease our no-show rate, to really make sure people show up for their appointments. So it's the patient navigation services that we also offer to get people into care. It's the transportation, being able to do that, and finding the right community partners to address what we can't tangibly do on site.
That's great. And these are tough financial decisions for a community health center. To think about, the investment of a jitney service, you're counting on the fact that this will have a direct correlation on a patient's outcome. In a value-based world, we will be reimbursed based on the outcomes of the patients. And that's a lot of gray math that we're still figuring out. But a health center is being asked to identify these issues, invest the resources with the hope that the outcomes improve. So that's great. So we talked a bit about, Jasdeep, you referred to the fact that, you're at a place where you're starting to screen patients at Ryan Health, you're collecting data, you're understanding the social needs of your patients. But, internally with our clinics, there's a lack of human resources, and there's still some technical challenges. So what I would love to talk to next is within our clinics, what have been some of the, how have you identified the staffing at your health centers that do the initial screening? So there's a common screening tool called Prepare. It's an acronym. And Prepare is just a standard screening tool that gets embedded into your medical record system. And it provides a sort of checklist for a health center staff to go through. It's a lengthy survey, and it's one of many surveys that health centers can choose. So I'll ask, and so with the screening of choosing a tool, you also have to identify the staff at your health center that will be best equipped to screen patients and asking these very sensitive questions. So how have you kind of taken a step back and identified the staff to kind of go through the screening process?
So at Ryan, there was a definite discussion about who's going to do the screening and when it will be done. There was discussion about maybe using front office staff, but then the concern was, how are we going to train the staff? Do they have the skill set? What about motivational interviewing? So that was one discussion. Then another group, we met again, we had another discussion, how about nursing staff? But again, in an FQHC world, the nursing staff is, they have vitals to do, they have tests to administer, they have labs to collect. So there was all this discussion. It was kind of putting the project at a bit of a delay. So we didn't know who exactly was going to administer the survey and when it was going to get done. So I came up with a beta app working with our EMR to have the survey be self-administered on an iPad. So this way, the patient can sit, answer the questions, and then it gets directly fed into our EMR. Provider can review it, and then that way make the necessary referral or connect the patient to the resources they may require. So it has been a definite challenge with deciding how to move that forward, but the technology is there to help assist as a tool to screen and get patients the resources they may require.
So we've had similar conversations. We're at the point where through the rooming process, when a patient is brought into the exam room, the medical assistant right now is the one facilitating the collection of that survey. Again, motivational interviewing being one of the ways that we've trained people in the past and have to continue to train. But all these surveys continue. We have so many other surveys to complete. There's such high demand for data and for information that the first 15 minutes of most visits feel like you're collecting nothing but data and asking questions. And it does become challenging on two parts. One, the patients don't want to do all of that when they're not feeling well or they're new, so you have to space it out. So it's hard to capture everyone timely, obviously, because you only have so much time. And if you do it over and over again, you will hopefully eventually get all the information. And we have tried in the past using technology like iPads and putting them in the waiting room and having people self-administer. But that also requires a resource. You need someone to support that. You need a physical body to be present to help collect that information. Because health literacy, computer literacy, technology literacy, whatever it is, that those are all the variables that do get in the way of getting all the information that you need, and the people and patients' willingness to fill out all of that information, because we're asking a lot, right? We have to collect all the stuff for the UDS, we have to collect, so there's a lot of overlap, and sometimes all that overlap, it just becomes too much. So it's trying to figure out the most efficient, effective way to do it. So, we're going to try to do this at least once a year at an annual visit. Can't do it at all of them. So, the first visit in that year, we're trying to collect as much information as possible. But those are the big challenges.
Great. And Adena, I will come back to you, but I have one more
No
question
worries.
for our health center folks. Something like collecting SDH, the screening tools are long, so it could take a lot of extra time in that patient's visit. And remember, they only have 15 minutes with that doctor, so we have to find a way, such as using iPad technology, to make use of time in the waiting room. You need to find the staff that are available and trained on how to ask these questions. You need to have protected, confidential space in a clinic, also hard to find, to ask these questions. So sometimes it's better to start really small with a pilot and just choose like a subpopulation that you want to start screening. Are you screening all of your patients, or have you decided to just take a smaller bite with a smaller type of patients?
So with that pilot that I mentioned with the iPad, it was a smaller population. It was one provider at our Harlem site for a patient who came in for a physical or had 2 or more chronic conditions, and the patient was handed this iPad not in the waiting room, but in the exam room. So patient just fills it out. It's in English and in Spanish, and it's not the full prepare. There were a select group of questions that were decided to be the main domains that we were asking. So it was translated, and then patient fills it out, completes the survey, and then the nurse just imports it into the progress note, and then once the provider comes in, they review it. So it did start as a small pilot, but other departments and other teams have noticed the benefit of administering that on an iPad and how it can help. So we do hope to roll this out with some other groups at other sites. So our Healthy Steps program and our mental health clinic will be the next phases that we want to implement this with.
That's great. Some of the clinics prefer to do mental health just because those that work in behavioral health tend to have the communication skills to ask these questions. And Tom?
We're doing a little differently. It's more on visit type. So new patients and annual visit patients are getting the form, and the follow-ups when they have their annual will get screened.
Okay.
And obviously, there's always the exception to that rule. Your higher risk patient that you know about, we are making sure we are filling those out for them as well.
Very good. Thank you. And Adena, from a funder's perspective, in terms of, right, you may not have that direct communication with your clients about collecting the data, but for your programs that you fund, what kind of information are you collecting about, they call environmental scans or community needs assessments, so what is your organization's method of really making sure that the organizations are really collecting accurate information about their communities?
Yeah, I think our partners love and hate us. We ask for a lot of data. So I think clearly understanding the demographics of that community, the needs of that community is something, given our mission and focus on underserved, poor New Yorkers, is incredibly important. So our partners provide probably a ton of that data. I think the social determinants of health kind of is a new area that we're also kind of, as our partners begin to collect that data for themselves, we're beginning to kind of gauge and ask a little bit more about, also so we can better understand, are there kind of ways that we can intersect the programs that we fund to better serve this population? Can we provide kind of more access to benefits? Can we provide access to food at these sites? Because we know that is a huge need at some of these health centers. So I think it's kind of in the early stages of that, but I think we've kind of historically asked for a lot of kind of information about the patient population and what their needs are are they currently homeless? Are they kind of, what are the language barriers, kind of, but I think it's also probably what you're all experiencing. It can be very sensitive and it can be difficult for our partners to get that information, and that's something that we are very understanding about as well.
That's great. Also, from the community health center perspective, in terms of collecting data on your patients, are you hoping to use any of this information to seek grant funding, maybe go to the health plans to say, our patient populations have a lot of complex issues. Can we negotiate a different contract or reimbursement to help us get jitneys or a lift, or kind of hire some of the staff that we don't currently have such as it would be wonderful to have more case managers. You know, right now, case managers, if a health center has them, it's because of a grant. So how are you hoping to use some of this SDH? You know, A, taking care of patients, but B, advocating for more community resources once you know what your patients need.
It's interesting, Kevin's our Vice President for Development and Grants, and we were talking about this on the way over. You know, operational grants are very important for things like this to really make sure that we can demonstrate what our client need and patient need is. I mean, if you have the data, you have the information, it should be used to expand programs, to expand services, to bring more funding to the organization so that we can continue to do the work that we do. And you know, it really is necessary in the form of grants to be able to, you know, because a lot of these services are not reimbursable, and the majority are not reimbursable. And to have resources that are going to assist, you know, and you know, a medical assistant who's occupied with someone doing a survey is being taken away from another one who needs an EKG or needs their blood drawn, and then you have to up staff, and you know, those things are very challenging when you have a very tight amount of money to run your operation to start with. So if we don't have, you know, the data, we don't have the opportunity to really look for those grants that will bring in more funding. It's always about what's the opportunity next. We have a ton of data, we try to use it, we use it well, and we've done a lot of expansion over the years because of that information that we have, which is why we've even expanded now to our women's health program, is because that data was more available to us and we really needed to do something about it. So that was a response. So definitely need more funding.
Noted.
Gina's contact information after this panel. And then I'd like to transition to just the discussion on technology. You know, part of collecting social determinants of health is this hope that we can better engage our patients. Once we can kind of address their social issues, we can engage them in taking better care of themselves. And in terms of engagement, you know, there's a lot of technology that's floating out there. And I'd love to hear more about any innovative uses of technology that you've been successfully or unsuccessfully trying with your patients in the hopes of trying to engage them. And we talk about patient portals, emails, text messaging. And Adena, also, if you've seen anything from the funder's perspective, you know, any kind of tech solutions that have been tried. Because it's true, right? We all have cell phones, and as much as people talk about low-income New Yorkers not having cell phones, everyone has a cell phone. And if patients are in a homeless shelter, they have a cell phone. So to kind of stop with that myth and think about, well, how do we use our phones and still be HIPAA compliant? How do we kind of think about using that technology to engage our patients, especially those that are having kind of social and medical issues?
At Ryan, the technology we're using, it is our patient portal. We also encompass some campaigns through the messenger. The messenger also allows patients to communicate with the provider. And then one of the innovative solutions that we're trying to leverage Health IT with is the tablets for the screening. There's, you know, pros and cons with technology. When we implement a project, within the first year or two, there's always this great attention, but then to have it sustain and actually, like, you know, run with the long-term hopes of hoping that project gets the patients the care, that's a bit of the challenge we're at right now, because we implemented a patient portal 2 years ago, you know, high utilization, high patient engagement, but now we're at a point 2 years later where the utilization has dropped, and we're trying to look for more innovative solutions to get patients engaged. So we're trying to leverage technology, trying to leverage Health IT, but the challenge is that we can implement a project, but in hopes that it's sustainable long term.
So I would agree with that. I think there's a lot of sustainability issues around the portals. We use them. We use text messaging for appointment reminders through our EMR. If you get 10% of the people to actually respond to that, that's a success. You know, everyone does have a cell phone, but if they don't pay their bill, we can't reach them. And that is the big challenge around it is, when we send the text messages, we can't guarantee people are getting them. We can't, be sure that they're using the technology appropriately. Patient portal has definitely been a successful thing for some. We would love to see it be more helpful to others. But again, it's the level of engagement. We've got to look at the technology is there to be used and to expand our ability to communicate, but it's the education that's missing that we need to work on. Is educating patients and clients how this can optimally improve your health. I remember in a former practice, I had a doctor that was using the portal for a patient who was diabetic and their numbers were out of control. And she literally, with a daily to every other day message through the portal, was able to reduce someone's A1C from 14 to 7. And that was remarkable. She changed somebody's life because of her ability to quickly message and that person to get a text. That story could be many stories. It's getting the people and the patients to understand the importance of it. But again, with the populations that we work with, we have to make sure we're building the right campaigns, that we're speaking the right language, that we're bringing about the information in a way that it's tangible for them to want to use it. And I think that's the biggest challenge. It's there. It's the wanting and desire and not getting overwhelmed with the amount of information that is now available to them as well.
Yeah, and I think at Robinhood, we kind of view technology as potentially a really incredible opportunity to create low-cost, scalable models and really the integration of kind of evidence-based traditional models with a tech component. One of the programs that we currently, and organizations that we currently fund is a Cecilia Health, which delivers a diabetes management program via telephone as well as a tech platform. So connecting certified diabetes educators to individuals, and the certified diabetes educators across the country can kind of really serve the patients at whatever time works best for them, can be via text, be via phone. So it's really about how do you meet the patient where they're at. And tech can be a really powerful tool in that. I don't think tech is the answer always or for everyone. I think it's really about creating a continuum of care and how do you use tech for certain patients and knowing that certain patients engage best with that. How can you use in-person kind of health providers for those patients that need it? I think the other thing that we're exploring a lot in terms of the integration of health and creating scale across the system is thinking about telehealth and telemental health and how can we kind of invest in solutions, especially for underserved communities where often those types of technological advances haven't really been brought to them. And knowing the incredible amount of barriers and challenges that this population faces to just get into the door of a health center. So, yeah.
Well, great answers. You all spoke to the technology, but the fact that to make the technology adopted and used, you have to think about the people, both the provider side or the social services side and also the user, and understanding how to use it and why to use it. So I have another question. Jasdeep, a while ago, kind of earlier in the panel, you had talked about the difficulty of, once you identify a patient that has a need and then you refer them out to a social service, not knowing if they've gone or not. Mm-hmm. And there are a number of platforms that have been developed. I think there's like 5 to 7. They keep growing and merging. Where, the idea is that, a health center will join this platform and then we'll know the social services in our geographic community. We send patients, but very few of them have like an active communication, like bi-directional feed. And I looked at a crosswalk recently, and very few actually will communicate back with the referring provider to say, oh, your patient came to our shelter. And so that remains a big gap of being able to coordinate care for this patient between a medical and social organization. It's hard enough to get 2 medical organizations to speak to each other. So the reason I bring this up and the question I want to ask is, what do you see as being a possible solution, or what is your wish list for being able to keep in touch with that patient about, where they're going, are they accessing services, are they having challenges? Maybe we sent the patient to a food pantry and they're hypertensive and nothing was appropriate for their diet. How do we really make sure that we are doing what's best for the patient if we're not able to really track? Am I making sense?
Mm-hmm.
Yeah. So maybe because as a system we're not able to really use that technology to track the patient, how do we maybe change that and find better ways to communicate with the patient about their experiences?
So one of the things we are doing at Ryan Health is that the Prepare tool, it's built into the social history. So if there is a need identified, whether it's food insecurity, and perhaps the provider is going to refer the patient to a food pantry, we put in documentation that the patient was referred to so-and-so clinic, to so-and-so pantry. Because it's sitting in a particular part of the EMR, when the patient does return, it carries forward. So because it's right there in front, the provider can then double check and be like, oh, I had referred you to, so-and-so pantry. Were you able to follow up? Did you get the support that you needed? So if the patient then possibly says, oh, well, I went, but they were closed on a Friday, provider now has the ability to document that and then possibly loop in another source. But putting it in a particular part of the EMR and in a place where it keeps carrying forward helps the provider have that conversation with the patient knowing, oh, this was done. Is this referral going to get closed, or is it something that needs to keep going?
Mm-hmm.
So that's one thing where we tried implementing with our primary care. But in terms if it was a different type of need that the provider couldn't address and it was more of a referral, the EMR is able to track referrals, and then from there we could see if the patient closed the loop or if it's still open-ended and the patient never got what they wanted.
So it's a matter of having that patient come back, asking them, and being prompted by the medical record.
But yeah, so the EMR, again, it's more of a tool, but I think ideally in terms of the wish list, we do want that bi-directional feed.
Yeah.
But how will, having a health center communicate with a hospital is a challenge, and having a health center communicate with a food pantry is going to be a much bigger challenge. But
I think that's a resource-heavy question, because I really think that we all need care navigators in our lives. I think we need people who, can hold all those cards together for us, because it really becomes a challenge with all the different EMR systems out there, with all of if you don't have an interface, if you don't have something built, you don't get the information. If you don't have access to that EMR, you don't have information. I mean, we've just started to use, Epic Care Link with Harlem Hospital to get the referrals and get the feedback just from the specialties that we send our patients to. We do have strong connections with a lot of our CBOs, but at the end of the day, there's a lot of traffic going between the two, and it really, someone needs to hold it all together, and whether that's a centralized care navigation system, but we're talking about very heavy and very difficult. We've been trying to figure that out for the longest, as we've gotten more complicated, we've been trying, but care navigation, care management, those kind of things do provide good support to people who are at highest risk. I think we have to figure out where the highest risks are and start there, and make sure the right resources are available to the highest risk population, and then work from there and see what works and find what's the evidence, what is going to be the best way to do that going forward.
Wow. And Adena, to spin it for your organization, for Robin Hood, how do you work with your grantees and the organizations that you support to kind of figure out if they have done a needs assessment for their community, they've built programs, that their programs in fact met the need that they said they were going to address? How is that information collected? How is it evaluated?
Yeah, I mean, I'll reiterate your point. I think from all of our partners, we've heard it's hard. Mm-hmm. It's extremely hard, especially around social determinants, to capture that information. You can make a referral, track referrals, but often you have no idea if a patient may tell you they've done it. They may tell you because you're their doctor, and they want to tell you what you want to hear. But knowing kind of for CBO, for on both sides, I think. For CBOs, often you're working with several different databases. You are maybe tracking things on paper or on a spreadsheet. So to have to then have that layer of you need to report back out to providers is incredibly, incredibly burdensome. So I don't think anyone has really figured out that answer, and I think it highlights some of the real challenges and difficulties with DSRIP and this transition, sorry for the acronyms, and this transition to value-based care in the system, because now health systems and health centers are being kind of told you need to kind of address the social determinants of health, but there's kind of no capacity building. And how are we tracking this? How do we know that this is actually having an impact on the health outcomes that we care about? So we don't have a solution at Robin Hood, but I think that's something that the health system in general, knowing and kind of placing the emphasis on how important social determinants of health are to people's physical and mental health, that's something that we need to better understand and better find ways to build capacity within health systems and CBOs so that we're bridging that gap.
Great responses. I didn't have the answer either, so I was hoping one of you guys would have a solution. And our health center folks are shaking their head because it is a complicated solution. We were hoping through, I won't go into too much detail about DSRIP, but it was a program that was really meant to create these networks of different CBOs and healthcare providers to really improve population health. And actually these platforms that help health centers connect patients to social programs, like Purple Binder, Amber, the Now Power, all just examples, are things that the DSRIP leads, which were hospital systems, had in place. But we found a lot of our community health centers did not realize that they had access to these platforms. So it's the fragmented nature of healthcare.
First of all, please, another round of applause for our panelists. And Sonia in particular, thank you for leading a wonderful discussion, asking some really, really good questions. I just wanted to close by saying that, we've talked about a number of social determinants of health here. I was exposed to this topic when I was, a neophyte in this space. I still am in some ways, but I was working at a free medical clinic in Galveston, Texas, which was the original inspiration for starting CareMessage, was that experience that I had. And I had a patient who was 74, 75 years old. She had a granddaughter with her, and the information that changed that patient's trajectory was knowing what time Walgreens closed that day. And so I think we sometimes forget that the most basic social determinant of health is access to information, and particularly access to the right information at the right time, because there's, particularly in this population, so much misinformation, lack of information, despite the overabundance of information that we all experience on a regular basis. That is the problem that we started CareMessage to be able to solve, is how do we create an opportunity for health centers to provide that right information, whether it's that appointment reminder that's going to get that patient to hopefully show up and make their appointment, whether it's information about that gap in care, like that cervical cancer screening, that breast cancer screening that they may not have realized they were overdue for, that could potentially save their life, or information about coaching for a particular chronic condition that will teach them in a respectful, authentic way how to cook healthy meals, especially if they don't have access to a kitchen, how they can cook meals that have less sugar or less salt. Those are the types of things that we focus on at CareMessage. And speaking about referrals, one of the things that we are doing in the coming year is actually building a product around referral management and helping healthcare centers across the country to be able to automate the process. And I really appreciated what, I forgot your name, ma'am, but from Morris Heights, you said, how do we empower patients? How do we provide the patient with the ability to be the center of their healthcare journey? And that's exactly what we're trying to do. How do we get the patient to provide that data in a way that has not been successful in such a long time? And because we are able to get 40, 50, 60% response rate in the other messaging that we're doing, and we have the support of over 200 health centers across the country that are helping us design this new product that we're building, we're hopeful to be able to learn from each of you as well as we think about this amazing problem, an incredibly difficult problem of managing referrals and connecting people to the right resources. So with that, I'll close. One last thing I wanted to mention, Blair, if you want me to talk about it, is we at CareMessage have been very fortunate to have been funded by this amazing organization called the New York Community Trust. It's a philanthropic organization here in New York that has invested a significant amount of capital to bring CareMessage to New York City and fund the implementation of CareMessage at New York City Health Center. So we do have we have a considerable interest from health centers across the city for this opportunity, but I think we may have one or two potential slots. So please talk to Blair here in the blue shirt if you're interested. But anyway, thank you so much, everybody, for coming, and thank you, KKR. Thank you, CareMessage team, Gia, Christine, Blair, Ryan. Really excited to have this amazing opportunity to have this conversation. Thank you especially to our panelists.